Whether you're looking for answers to specific life questions or simply hoping to become the best version of you possible, welcome to the Mental Breakdown and Psychreg podcast, where we offer insight, information, and strategies based upon research and years of practice as psychologists. So sit back, have a listen, and get connected with our hosts, Dr. Berney Wilkinson and Dr. Richard Marshall. Welcome back. Today's podcast is going to focus on the treatment of obsessive compulsive disorder.
Must be Saturday.
It must be Saturday. Our long form podcast to talk about treatment.
I just thought of something.
What's that?
You don't remember the Mickey Mouse Club?
Yeah.
You do?
Sure.
Not from the 50s, you know.
Well, no, not
or the 60s. Anyway, they used to have Wednesday was Anything Could Happen Day.
Yeah?
Yeah, Mickey Mouse Club. It was Anything Could Happen Day. So Saturday is Treatment Day.
Yeah.
Treatment
Day.
Sorry, a little bit of a pre-senile moment there. So this is Saturday, this is treatment for OCD.
Right. We're going to talk about treatment of OCD, and we'll kind of go through some of the different common treatments. We'll kind of allude to a little bit of some more dramatic treatments.
Dramatic is a good word.
And then we'll kind of end with some tips to help beat.
Right. As usual, there is the what is referred to as the gold standard. Okay. So we'll talk about that, the sort of typical evidence-based approaches to OCD. But this is a difficult disorder to treat. I mean, everybody acknowledges that it's not there's no cure for this. And so there are some rather bold, aggressive treatments for this disorder that we typically don't talk about. So I'm glad we're going to be introducing those today.
Absolutely. So I guess we should begin with the more common treatments.
Right.
And why not?
Well, and remember that we're not talking about anxiety.
Right.
Okay. We're talking about this disorder that has clearly defined obsessions and clearly defined compulsions, because the treatment is based on the interaction of those two things. I mean, this gold standard treatment that we're talking about is based on the interaction of the obsessions and the compulsions. Right. And you remember throughout the week we've been saying you have to have these two things. Otherwise, you have obsessive compulsive personality disorder.
Right.
If you like order and cleanliness and orderliness. But to have true OCD, you need to have these two things.
Right.
So the treatments address that relationship.
Right. Yeah. And I think we'll talk more about personality disorders coming up soon.
Another time.
So.
Right.
So, you know, the gold standard as it relates to the treatment of OCD is going to be in the family of psychotherapy, especially exposure and response prevention therapy.
And when we say psychotherapy, we don't mean insight-oriented therapy.
Right.
The kind of psychoanalytic
Right.
insight. That has not been shown to be very effective.
Right.
You're not going to talk yourself out of this, in other words.
Right.
And you can't rely on somebody else talking you out of it.
Right.
This is a very active, dynamic approach to treatment.
Right. So exposure and response prevention therapy are, I would still put them in the broad family of cognitive behavioral types of therapies. But basically, and we've kind of alluded to them a little bit throughout the week, and basically these approaches, you know, look at the obsessive thoughts and compulsive behaviors and work with the patient to help them create some, to sort of desensitize them to some extent, but expose them to some of these things that they're anxious about, and teach them strategies and help them overcome the anxiety that accompanies those thoughts and behaviors.
Right. The goal of these, sometimes you see it as ERP, exposure, and other times you see it as I don't know, they put a slash in there.
EX/RP.
EX/RP, right? But the goal of this thing is to weaken the association between the obsession and the compulsion.
Right.
Because remember, as we've said throughout the week, you use your compulsions to manage your obsessions.
Right.
And so what your brain has done is it's connected those two things very closely.
Right.
So what the therapies do is they try to weaken that connection.
Right.
That's the goal of these therapies.
Right. Yeah. So this and this type of therapy has really received some positive support through research and through clinicians using them to help treat people with OCD. And there are there are lots of videos and there's a lot of information out there about these types of therapies because they are so beneficial.
Because they are effective, right?
Yeah. Other therapeutic techniques include other things within the family of cognitive behavioral therapies, talk therapies. But as you said, it's really difficult to talk yourself out of them.
Right.
I've used, just as an example, I guess, of exposure type and response prevention type of therapy, I once worked with a teenager who he had an obsession and then some compulsive behaviors associated with orderliness. And so he had to keep his room, imagine a teenager, having to keep his room perfect.
Anomaly in itself.
And so he has a 7-year-old brother who would come in and move stuff and mess with stuff.
I remember this.
And so when the 7-year-old brother came in to do this, he would then have to spend, 2 hours redoing everything. Even if the brother just moved a couple of things, he would have to redo everything. And so the type of exposure and response prevention treatment that I did with him is we worked on a system where he would sit in his room and do some relaxation techniques, just kind of calming that neurological system down a little bit. And then he would move something. He would put something out of place, put a picture on the wall a little crooked.
He would do it himself. Yeah.
I would have him do it himself. And he would move it a little bit, or he would just get it to where it bothered him just a little bit.
Right.
And then he would sit there and not be able to, and he practice more of those relaxation techniques and just to keep himself calm. And I encouraged him to do it for as long as he could tolerate before it really got to the point where he was going to have to redo the whole room and then fix it, and that was fine. And each day, do that a couple times a day, every day, and see if he can, last longer and longer. And sure enough, after a couple of weeks of this, he came in and he says, Dr. Berney, I got great news. I didn't make my bed this morning.
Wow.
And this for him was a massive thing because he had to have everything perfect. So, but he just got used to being able to tolerate some of those things not being the way they were.
I'm laughing because of the Admiral speech at the University of Texas. Make your bed.
I know.
Do that first. You mentioned an important thing, and that's the relaxation techniques.
Right.
Because the other thing to remember is that you have to have some way to calm yourself. This is going to be this approach is an anxiety on purpose. It's purposely an anxiety producing technique. And so before you go into the therapy itself, you need to have a way to relax.
Right.
And one of the things that I have found, I'm working with a person right now, and this person has a very difficult time relaxing. She's not able to really find a good way to relax. So we're not ready yet to move on to the exposure because to force her to face it without being able to calm herself is a disservice at least and dangerous at worst at most. So make sure that somebody includes this. You have to have a way to relax yourself.
Yeah, absolutely.
Because it ain't fun.
No.
When you're confronting your demons, you have to have a way to keep yourself calm.
Absolutely. Absolutely. So you have to work on that in the very least.
Operative word here is work.
It's work.
And it's a lifetime of work.
And any type of therapy is going to be work, whether it's the exposure response prevention or it's cognitive behavioral or whatever approach you take. It's going to be work.
I teach a course on group therapy, and it's the same thing. And I repeat week after week, you have to practice this stuff. You have to go home, and you have your group for an hour.
Right.
But the real work is done in your practice from week to week.
Right.
Because then you come back to the group and say, okay, I tried this, and this is what worked, and this didn't work. Therapy takes work. It takes effort. Yeah, you're right.
Yeah. And I think that we oftentimes forget that. We think, it's just going to happen, and it doesn't. It doesn't just happen.
And it's not taking a pill.
Right.
But remember that taking a pill isn't going to do it either.
Right.
one of the things you always hear, whether it's ADHD or anxiety or depression or OCD, medication is helpful, but it's not a cure.
Right, because as soon as you stop taking it, right,
you're still going to have to do this work.
Right.
I mean, the pill will help you do the work. I think that's how I always explain it to patients, is that taking medication makes it a little easier to do the work, but you have to do the work anyway, and it takes time, and it's not easy. It's an effortful process.
Right. So some other, besides cognitive behavioral therapy, other...
But this exposure therapy is under cognitive behavioral therapy. There are other, but you're going to talk about the other therapies under cognitive behavioral, or are you going to move to other therapies?
Well, both.
Okay, I'm just trying to keep up. You know me.
It's tough to keep up sometimes. Go ahead.
No.
So other cognitive behavioral therapies. You have, depending on what the source, if we can figure out the source of the trauma is, or of the obsessions and compulsions is, there may be trauma related, and so we have dialectical behavioral therapy, which we've talked about before. We have, again, when it comes to cognitive behavioral therapy in general, we're talking about exploring our thoughts and our ideas and seeing how they influence our behavior and work to change both of them sort of at the same time. I also like, and we've talked about this before, metacognitive behavior therapy, where you're thinking. I like MCT because what it does is it encourages us to think about why we're having the anxiety or the obsessive thought as it relates to this, because sometimes those obsessions are telling us something. Germs, for example.
Right.
Well, if you, at its root, we should be cognizant of germs, and we don't want to spread germs, and we don't want to do that kind of stuff. So what is that obsession trying to tell us? Well, that obsession is trying to tell us that we're worried about our environment, and so we need to look and see why we're concerned about our environment and do something about that. That's going to help the root cause.
Right.
If you're obsessed about checking the doors, why is it that you feel unsafe? Why do you feel as though something bad may happen? And then explore those kinds of issues in therapy.
Right.
Yeah. So that's why I like
because one of the interesting things you might run into if you read a little bit about OCD is doubt and guilt.
Right.
Those are the two devils that you're dealing with here. The devil's in the details, and people who have OCD tend to have higher levels of doubt and guilt, and so you doubt yourself, regardless of how many times. You check the door, but you have to go back and check it again, and you did it, but you have doubt, okay, and the other is guilt, okay, and so you're trying to assuage those two things, with your compulsions,
yeah, and again, all of these therapies are difficult because you're talking about sort of automatic thoughts that come in there.
And also adaptive thoughts. You should be afraid of germs because they can kill you.
Right.
You should be afraid not to lock your door because it might be dangerous.
Right.
So we're talking about a normal behavior that has that plays an abnormal
excessive
role in your life. But it's normal to do all these things.
Right.
It's normal to wash your hands.
Yeah.
But not 50 times a day.
Right. Yeah. So that's where this really does get to be more challenging.
Yeah. In some brains, this happens.
Right. Yeah.
You get this very strong connection.
Right. Right. Do you want to move on to other types of therapy, or do you have what else do you want to say? Go ahead.
About cognitive behavioral?
Yeah.
Well, would you put thought stopping in there? Flooding?
I would put flooding in with maybe behavioral.
Okay.
Wait, what kind of flooding are you?
That's good.
Okay.
Yeah.
All right. So when it comes to just behavioral techniques, we're talking about like systematic desensitization, and again, I would put flooding in there. So if you're anxious about something, we're going to just put it on you.
You want to quit smoking? Here, put 3 cigarettes in each hand, and we're going to put a fan in front of your face, and we're going to flood you with that smoke until you can't stand it anymore.
Right.
What are we dealing with? That's just that. You can do that with some people, with some things.
Right.
But again, you can see how that could be traumatic
Yeah.
for some people.
Yeah.
I mean, you're afraid of germs. You don't want to splash somebody with
Yeah.
muddy water.
Right.
So
Yeah.
be
If you're
careful.
if you're afraid of snakes.
Don't fall into a box of snakes.
Yeah.
Indiana Jones.
That's right.
Right.
Don't take that approach.
Right.
But with some things, it does work. There are times, thinking about germs. Individuals who are so concerned and anxious about germs that they won't check the mail, for example, because the germs and everything that's out
You
there.
mean the mailbox?
Yeah.
Oh, not email.
Oh.
Oh, okay. Oh, just asking. Go.
So they won't do that, but so you have a therapist come, or you have somebody that's going to help you come in and you get the mail, and so you're touching the mail and you're spreading the mail. I saw a video of somebody taking the mail and just wiping it all over the couch and all that kind of stuff, and
That could be traumatic.
it could be. And of course, in my mind, I often think about what would happen if it just so happened that person caught a cold the next day. It's over. You're never
lifetime of therapy.
Right. You may never
because
overcome
that. Again,
that
what
confirms.
it does is it tightens the bond
Right.
between those two things.
Yeah.
Anything that tightens the bond, accidental or not.
Mm-hmm.
Is,
Yeah, one of the videos we saw in training and stuff had a person wiping the couch with the mail, and the woman's holding the mail, and she's like, "I'm pretty anxious," and they go, "Okay, now I want you to pick up your 1-year-old."
Oh no!
And so she was like, "Oh my gosh," and she became tearful and everything, but she did it. And again, the first thing I thought of is, what if that baby catches a cold tomorrow?
Man.
Because as soon as that baby catches a cold, again, it's over.
You know
she's
where
not going
else-
to participate in therapy anymore.
The other place you can see this agony is Hoarders.
Mm-hmm,
Okay,
mm-hmm.
you can see the same thing. You see how difficult it is
Right.
for those people to let go of these things. They're
Right.
meaningless. They don't use them. They never use them. They just can't let go.
Right.
Mm-hmm.
Yeah. So, all of this stuff requires, all these behavioral techniques do require, again, we're going to go back to those relaxation techniques. You really have to have those in place, because the person has to be able to calm themselves and pull themselves down to make sure that they don't get so overwhelmed that they have a panic attack or something
That's
like
right. I've mentioned my daughter's frog phobia,
Right.
and I can't. She won't even discuss it.
Right.
I mean, that's how far away from treatment she is. That she's, I know, but I'm not even going to talk about it.
Right.
And so imagine if I brought up if I brought a frog into the house, she'd need
Wait
a
till the next time I
cardiologist.
come
She would
over.
need a cardiologist. No, really, she
She couldn't handle it.
No.
Couldn't tolerate it. Yeah.
And so you have to be careful, because there are serious implications
Mm-hmm.
in these treatment approaches.
Yeah.
And so a therapist has to approach these. If you're looking for a therapist, make sure you get somebody with some experience, because it has to be approached very carefully.
Yeah.
You don't just begin therapy.
Mm-hmm.
You have to do it carefully.
Right. Now, there's other forms of therapy that would probably fall into cognitive behavioral therapy, as well as maybe behavioral and some other areas as well. But things like, and to me, these therapies are, again, very challenging to do, and maybe even more challenging than exposure and dealing with that. And that's things like thought stopping.
Right.
Again, a lot of these thoughts are automatic, and I become, it depends on the person, but I'm always a little bit hesitant when it comes to saying, okay, when you have those thoughts, let's figure out a strategy to help you stop those thoughts.
Right.
Because, and we've talked about this, especially with metacognitive therapy before, if I tell you not to think about an elephant, you can't help but think about an elephant.
Right.
And so when you have some of these obsessive thoughts and you say, okay, I got to stop thinking about those obsessive things,
Right.
now you're thinking about it, telling yourself not to think about it.
You know where we see that this frequently comes up in recent divorces, where one of the partners feels really aggrieved, or they feel like they've given up too much. And whenever you untangle two people, it's always a painful process, typically a painful process. But when you add injustice to it, like when somebody feels that it wasn't a fair division of property, for example, you really begin to obsess over that. And you say to a person, I know you lost your pensions or half your pensions and they were really yours, and you didn't want to give them up. But you can't keep obsessing over this because it's going to because it leads to very depressing, dark anger places. And thought stopping might be appropriate for that because you know what you're doing, you know why you're doing it, you know that it's not going to you can't change the court order. And so the best thing to do is when you have that thought, just to stop it. Okay. But that thought's going to go away anyway. Eventually, you're going to get over your anger. So this is not a classic case of obsessive compulsive disorder. Yes, you're obsessing, but it's temporary. And thought stopping would be effective. It's less effective when you have a true obsession, a lifelong genetic. You just can't stop thinking about it. If you could, everybody would do it. But thought stopping and in fact, thought stopping isn't very effective with true obsessions.
Yeah. So, any more about psychotherapy?
Thought stopping, systematic flooding, saturation, ACT. ACT.
Acceptance and commitment therapy.
And I do like that.
Yeah.
Because, and I have found that to be fairly successful, is that I say to people, stop fighting it. When you fight it, it's like, stop thinking about the elephant. You can't stop thinking about it. Okay. So just accept the fact that you're going to have this little creature thing in your life. And stop fighting, because the more you fight it, it's like quicksand. The deeper you get. Okay. So you have to have awareness. That's why the cognitive therapies work so well, because they all begin with awareness. Know what you're struggling against. Know the battle you're facing, and it makes the treatments a lot more successful.
The last therapy that I'm going to mention that's not listed in the article that we're posting about it is one that I've just seen referred to as paradoxical therapy. And that is, while you work to not engage in the especially compulsive behaviors, and this is especially good for compulsions as opposed to obsessions, instead of engaging in the compulsive behaviors whenever it strikes you, you identify a very specific period of time in which you are allowed to do the compulsive behavior. And so, you may work to hold it all day and don't engage in the compulsive behavior, all day. And, from 6 p.m. to 7 p.m., go wild, do it as much as you want. And then you can't do it again until 6 o'clock the next day. Or, you fight and not do it, kind of depending on what the compulsion is, fight and not do it until the last 5 minutes of the hour or something like that, depending on how frequently they come and everything. So for some people, that type of paradoxical treatment, sort of behavioral treatment, it can be effective.
I was thinking about smoking, using that, or other things that I can think of that you would say to the person, because one of the problems that we have with obsessive compulsive is that you don't want to give it up. I mean, you're afraid of giving it up. You think, you mean I can never think about that again? No, you can think about it. Just confine it to this.
Well, once again, just like other anxiety disorders, it's the thing that makes it feel the best, doing it or obsessing over it or engaging in the compulsive behavior, is exactly what relieves it the fastest.
That's right. So give yourself permission. If it's not damaging you in any way, if it's not affecting your life in some significant way, that works for some people, because the problem is the fear of giving it up.
So now we're going to shift to medications. And this section actually is pretty quick.
Pretty short.
SSRIs, antidepressants, for the most part, are generally effective. The benzodiazepines that are often used for anxiety-related disorders aren't as effective here because of the way that obsessions and compulsions tend to work. So typically we go with SSRIs, Prozac, Paxil, Zoloft, those kinds of things.
But know that they take a long time to work.
They take a while to work, and usually the dose has to be kind of kicked up a little bit higher than other anxiety disorders. So,
or even depression.
Right.
You know, that for this disorder, it may take longer to have really effective medical treatment.
Right. And you do have to avoid some of those things that make other things related to anxiety worse, like smoking and caffeine and other stimulant-like things. You have to watch out for that stuff because it could exacerbate your symptoms.
Yep.
So now let's shift to some of those. This is in another article from the International OCD Foundation, and they talk about some what they call more dramatic treatments. And this, to me, really is just for people who have really severe OCD that's not responsive to most other things.
Right. You don't start with this.
Right.
Okay. And you make sure you've tried everything else. These are not going to be used unless it's documented that you've tried everything else.
Right.
And everything else could even be, because one of the things we didn't talk about is these treatments can be done on an outpatient basis, like in a group, or they can be done on an intensive, they can be done group or individual, an intensive outpatient or inpatient treatment, residential treatment, where you actually go someplace and live for a month or two. If you've tried all of those things and nothing works and you're struggling or your life is falling apart, there are some much more aggressive therapies that are available. Some are, well, let's go through them.
Yeah, and we'll just go through them quickly because, again, most of you will never.
70% of people are going to respond.
Right.
Okay, this is for that group.
And not even that 30% would need something like this. It's a very small portion of even that 30% that would.
Well, no, I guess we should divide it in half. There are several of these aggressive approaches are not invasive.
Right.
And they're not going to hurt you.
Like transcranial magnetic stimulation, TMS. That's something that can be done outpatient.
Right.
It's sort of a neurostimulation, but it's all external. And there are lots of outpatient clinicians who do things like that.
Right.
And so, again, it's a little bit more of a dramatic treatment because it is, in essence, applying some electrical stimulation to your brain. It's not like ECT, electroconvulsive therapy. It's not to that extent.
Not confuse those.
But it's, but it is,
you are bombarding your brain with some stimulation from the external stimulation.
Exactly.
And people struggle. Some people struggle with that.
Right. Just with the idea of that.
Right. But it's not harmful.
Right.
I mean, you could. We have units here, right, that we can use.
Right. Right.
And other physicians, psychologists have used it without any risk.
Right. But going sort of the next step up from that would be something like deep brain stimulation. Usually I've seen this used more for like things like Tourette's disorder, which is a different. I almost want to say that Tourette's is it's not really a type of OCD, but there are significant similarities between OCD and Tourette's disorder. When you think about the urges and the pressures that the person feels to engage in the tics, but certainly people who have debilitating Tourette's disorder, deep brain stimulation is very effective for them. But basically, we're talking about, just to put it simply, the insertion of electrodes into the brain, focusing on particular regions of the brain with the goal of stimulating those areas to relieve the symptoms.
That's more invasive.
Very invasive.
Right, because we're talking about transcranial is, pads
on the skin, basically.
On your scalp. Now you're talking about...
actually into the brain.
You're going into the brain. That's an invasive procedure.
Deep brain stimulation has been very effective with other disorders, other conditions such as Parkinson's and things like that. But it's only used in really severe cases of OCD. Other things are brain surgery itself.
There is a part of the brain that kind of controls all this stuff. I mean, there are some subcortical structures that we know are related to OCD. Some of this is chemical, but some of this is structural. Okay. there is brain surgery for this. And it sounds a little bit like Frankenstein and all that stuff. But if it's done carefully by somebody who knows what he or she is doing, some patients have gotten relief. You see how cautious I'm being right now.
It reminds me of trephination. Remember that?
Oh, yes.
Don't look that up unless you can handle it. It's a very old technique used in some cultures, tribal cultures, where they just put a hole in your scalp and hope that helps.
But the sad thing about brain surgery,
not with chisels.
Yeah, it's like
no anesthesia. Oh man.
But brain surgery has gotten a bad rap because of the lobotomy. Okay, lobotomies were done kind of the turn of this through the first half of the 1900s, 20th century, and brain surgery got a bad rap.
Right.
There are brain surgeons who are doing miraculous work all over the world.
Yeah.
But whenever we hear brain surgery, we think of the lobotomy.
Right.
And we don't want to repeat that mistake. Right. Well, electroconvulsive therapy. There was a time when ECT was a gruesome procedure because they were using too much electricity. Right. Today, ECT is far more benign because they're using far less electricity. Right. And so brain surgery's gotten a bad rap. But whenever you do brain surgery, there are risks.
Right, absolutely.
It's a delicate organ that we don't know much about.
Yeah.
I always think of the brain as the ocean. Here it is, and we don't know much about it.
Right.
We don't know much about the brain. But there are some successful techniques that we ought to be using.
Yeah. In the article that we linked in the show notes from the International OCD Foundation, there are links. Each of these have a link. So brain surgery, something called gamma knife.
You're going to hear about gamma, GAMMA, knife. Like
a knife. Deep brain stimulation, and all of these. There's links, and you can follow those links and learn more about some of these things because they are extreme and not very common. But if you're interested in learning some more about that, you can check that out there.
And we mentioned pandas the other day.
Right.
The sort of sudden onset OCD related to the streptococcal infection. In that case, the medical treatment would be antibiotics. It's a whole different thing. So pandas, or now PANS, they actually have changed. They're changing the name from panda to PAN, PANS. So that is due to an infection. You treat the infection with an antibiotic.
Absolutely. So we're going to wrap up today with 10 things that you can do to help to work to overcome OCD.
A wonderful addition to the literature, we give this person I wished I had done this.
Yeah.
So another one of those things that, wow, I wished I would have done this.
Right.
A great thing.
Fred Penzel.
Right.
This is from beyondocd.com, and again, we have the link in the show notes.
Great.
And this is his list of 10 things to do to help overcome it. And the first thing is to recognize
I have three favorites.
You have 3 favorites?
I have 3 favorites, but I want to do all 10.
Okay. The first thing is to recognize that OCD is chronic.
Right.
It's a chronic condition, meaning that just like asthma and some
Diabetes.
other mental health or other illnesses, it's something that lasts a long time, and you're going to battle.
This is a chronic disorder.
Right.
They get used to the idea that even if you learn to effectively manage it, it's not going anywhere. Okay.
Yeah. So we don't have a cure for it.
Right.
We can work on and develop strategies for overcoming some of it, but there's not a cure.
Right.
The second thing is that 2 of the main features of OCD are doubt and guilt, and you mentioned that a few minutes ago. Right. But that's not one of your favorites?
No, not yet.
Even though you already mentioned it.
I mentioned it.
So no spoiler there.
Now we're getting to
Number 3. Number 3 is one of your favorites. Although you can resist performing a compulsion, you cannot refuse to think an obsessive thought.
And that's what we kept saying.
That's the elephant.
Right. So stop fighting it.
Right.
You can have compulsions without obsessions. Okay. Those would be dealt with very differently. You just can't fight these obsessive thoughts. And the more you fight it, the worse it's going to be.
Right. Number 4 is something we talked about a moment ago, and that is that for OCD, cognitive behavioral therapy is the best form of treatment, even above medication.
Right. That's right.
Because medication tends to take much longer, but cognitive behavioral therapy teaches you the skills and techniques that you need to manage the symptoms on a day-to-day basis.
The reason this one was one of my favorites is that he also talks about what isn't very effective.
Right.
He talks about CBT being good, but he also talks about things that don't work as well.
Right.
So I like that one.
Yeah, check that out. Definitely.
Right.
Number 5, while medication is a help, it is not a complete treatment in itself.
Correct.
And that we talked about that a moment ago as well, that, medication may help curb some of the physiological or some of the symptoms while you're taking it, but it doesn't cure it, for one, and for 2, it doesn't guarantee that you're going to have any control over it in the event that you stop taking the medication. So you still need the cognitive behavioral strategies, really. So.
Right.
Number 6, you cannot and should not depend upon the help of others to manage your anxiety or to get well. And I think, to me, this is one of the most important ones, because I'm always concerned when I'm talking with people and they say, I say, well, what do you do when you're stressed? Well, as soon as I get stressed, I call my mom or I call my friends or I do this. And when you're unable to manage some of these things on your own and you rely upon somebody else to manage your mood or your anxiety or your stress or anything like that, that is immediately a red flag to me that we need to work on skill development, because if you can't manage some of this stuff on your own, somebody else isn't always going to be there.
That's right. Yeah, don't rely on others. But no matter how we do this, all the therapies we've talked about, they are things that you are going to have to do, and you're going to have to be able to do them alone.
Right.
Okay, so that's just how this works.
Right.
So don't rely on others. This is a battle that you have to wage.
Right. And number 7 gets to why we do these podcasts, really. And that is that the goal of any good treatment is to teach you how to become your own therapist.
That was my other favorite.
It was?
That was my 3rd favorite, number 7.
And the reason I think that this one is important, again, is because, like I just said with the purpose of this podcast, we want to help teach people how to do this stuff on their own. Coming to see us is great, and if you need the support and the help, come see us. But if you in your day-to-day life, if you need to be able to manage some of these things on your own and be able to think about some of these things on your own, and good treatment should do that.
That's right. And frequently people will come in and say, well, tell me what to do. What should I do about it? And I said, I can only tell you what is possible. You have to tell me what works for you. And I'll say to people, can you do relaxation? I said, no, I've tried that. I can't do relaxation. Right. Okay. If we know that about you, then we know what direction to go. Right. Or I've never been able to do thought stop. I've never been able to do this. I've never. Fine. That's important for us to know. Right. It tells us what you're able to do, because you have to be your own therapist. Right. Nobody else can do. You have to decide. We can tell you what's available, what you can use, but you have to select the ones that work for you.
And even beyond that, what you're not willing to do. People who say,
that's true.
People who say, oh no, I can't give that up, or no, I can't, I'm not going to do that.
Okay, that's fair.
Okay, I need to know that.
People's, this imagery, people, imagine yourself on a beach. Yeah. I can't do that. No. As soon as I start to relax, I think, wait a minute, I have 27,000, I have too many things I have to do. And that doesn't work for me. Right. And that would be important for me to tell my therapist, look, I can't do that. My life isn't structured that way.
Thanks for telling me, so now I know.
Now you know what works with me, right?
Yeah. But this leads to number 8, and that is sometimes our intuition works to get us to do something about and we have to sometimes go against our intuition, because after all, if we typically live our lives by our intuition, and if so, and you're still having these obsessions and compulsions, that means that your intuition may not be completely informed to help you get over.
It could be your intuition that got you there in the first place.
That's right.
So don't rely on that.
Right. Number 9 is getting recovered takes time. This does take time, and this goes back to the fact that it's chronic.
Right.
It doesn't, anything that's chronic doesn't recover or resolve quickly.
Yeah, the medication effect takes a long time. Any other therapies that you do take a long time.
Mm-hmm.
Don't be in a hurry.
Right.
Okay.
Right. And the last one is to keep in mind that there's always the risk for relapse, and that goes back to number one, that this is chronic. There's no cure.
Right.
And so you may learn strategies to overcome it. You may learn skills to prevent it from interfering with your life.
Right.
But at moments of stress, at times when you're overwhelmed, there is the risk that it's going to reemerge.
That's right.
So you always have to be cautious and conscientious of that.
Relapse is always a problem because this is a deep-seated, very strong connection between obsessions and compulsions. It doesn't go away easily. You're going to have to work at it. There's always a risk of relapse, so be careful.
Right, absolutely. So, all right, anything else?
No, that's all.
That's it. So, all right. Well, that wraps up our week on OCD.
Right.
So, love to hear from you if you have any thoughts or opinions or ideas or experiences that you'd like to share with us. We'd love to hear that. But thanks so much for listening. Until next time, stay happy, stay healthy, and forget to be afraid. Thanks for sharing this episode of the Mental Breakdown and Psychreg podcast. Be sure to check out the show notes for links to follow us on Twitter and subscribe to our YouTube channel, where you will find all of our previous podcasts and much more. We would be honored if you would become a patron through patreon.com, where any donation you can manage will go to the development and creation of more content. Just visit patreon.com/thementalbreakdown for more information. Thanks again for listening. Have an awesome day, and we look forward to being back in your feed tomorrow morning.